All right. I think we can begin. Namaste sabailai. My name is Dr. Ramu Karela. I'm an emergency physician and one of the founders of the Nepal Poison Information Center. Thank you so much for joining in our monthly webinar. Today is a really exciting topic that we are very, very excited to have two amazing speakers that will be speaking on really important topics on acid base as well as organophosphates. Before we begin, I just want to remind everyone that the Poison Center is open 24/7 for anyone to call, any healthcare providers to call. The phone number is 450-2011 450-2011 त्यो तपाईँको फोनमा छैन भने कृपया त्यसलाई चाहिँ राख्नु होला र 24/7 तपाईलाई केही पोइजनिङका क्वेशनहरु छन् भने we have a group of experts that can help within the country, and we also have a large expert support system outside the country that can guide poisoning care. So please keep that in mind. And as you all know, we have a monthly webinar, so keep it on your calendar to join this. So before we go, I'll just like to introduce our team as well. We have two new specialists in poison information that have joined our Poison Center. So now we have total of 5 total spies that are working in the Poison Center. And the two spies are here, Dr. Anup Pandey and then Dr. Apeksha Bista. So welcome to them to the team. And I would like to thank TUTH, Clinical Pharmacology Department, as well as Ask Foundation for their continued support in this work. All right, without any further ado, I'm gonna introduce our first speaker. Our first speaker comes he's joining us from Norway, from University of Oslo. It's Dr. Knut Erik Hovda. He is a senior consultant in the Department of Acute Medicine at the Oslo University Hospital, and he's also professor of medicine at University of Oslo in Norway. He has worked with the National Poison Control Center and has worked with MSF, which is Doctors Without Borders, since 2012 to develop a methanol poisoning initiative. He's doubly certified in internal medicine as well as in emergency medicine, and also has a PhD in clinical toxicology. And he primarily works on acid bases, toxic alcohols, critical care toxicology, as well as toxicology in the developing world. We are so excited to have him here for the next 30 minutes or so. He'll walk us through the metabolic acidosis and a sort of simplified approach for clinicians. Dr. Knut Erik, the floor is yours.
Thank you so much for that kind introduction, Ramu. Also, to all of you, thanks for being here. Thanks for inviting me, and my apologies for having missed out a little bit with the timing. So I planned for a slightly longer talk than half an hour. I will thus speed up a little bit, so my apologies in advance. Some of the slides I might just skip over that are quite more of a basic knowledge. And if time permits, I'll speak a little bit in the end about osmolality and the osmolar gap and the anion gap. If not, I'll focus on the blood gas without having a focus on those. So with that in mind, I'm going to turn off my camera and focus on the slides, and hope you will enjoy. First of all, I have a very short disclosure. I'm a CEO and co-owner of a company called Orphan Diagnostics, and we're trying to make a bedside diagnostic tool for methanol poisoning available. There's no available product at present, and I'm not going to focus with it either, but I just want to mention it anyhow. So what we're going to talk about now is focus first a little bit on terminology and definitions. Then I will probably skip the expected physiological response because that's kind of simple and you would probably already know that. Then I'll go into the main topic, which is a suggested strategy from you actually see the patient until you get your blood gas and you start your interpretation and go forward. We're going to look a little bit about the calculation of the deviations. then we're going to use some additional supportive tools, which is quite important. And if we have the time, eventually look at the gaps. First of all, these are quite basics, but we need to understand the definitions of alkalosis and acidosis and the respiratory and metabolic components. So first of all, the PCO2 being low gives us a respiratory alkalosis, whereas a low base deficit, meaning a high base excess and a high bicarbonate, will per definition mean we have a metabolic alkalosis. On the other hand, a respiratory acidosis is defined by a high PCO2, whereas a high base deficit or a low base excess and a low base bicarbonate will give us a metabolic acidosis. The metabolic acidosis can be separated in two, the ones with normal anion gap and the ones with increased anion gap, and I will come back to the two of them. This is my suggested strategy, and I've tried to make this strategy as clinically relevant as possible. And starting from your left, you will always have the patient history and clinical features to base it all on. And I would really want to emphasize the importance of dissecting the patient history, because there is a lot of small clues in the history. How did they find the patients who was there? How long time from the potential drinking of the patient until the symptoms started, etc., etc. Is there anybody else in the vicinity with symptoms which is similar? There's a lot of information in that history. Then you want to draw your blood gas. Whether you draw an arterial or a venous blood gas doesn't really matter. When it comes to the metabolic components, both of them will work fine. If you're looking at the respiratory components, you clearly want an arterial blood gas, but for the metabolic components, you can use either one. Then what we will focus on first, our step one, is how to interpret the blood gas. You can do that by what we call the Boston model, which was developed in the 50s, and the focus is there on the bicarbonate. You can also use the Copenhagen model, which we use, and where the focus is base excess. And the reason for why we use that, I will tell you quite soon. Regardless of which one you're using, you need to have a look at the strong ion difference, the SID. And why is that? Well, because having a very exact or very narrow window in terms of acid-base changes is extremely important, because that will determine the three-dimensional structure of the proteins, thus the enzymes, and therefore the function in our body. That's why we have a very narrow window where the body wants to control our degree of acidity. However, even more important is that we can never have a charge in our body. There has to be equal amount of cations on the positive side and anions on the negative side. So the strong ions would always be a stronger drifter or a stronger drive to in what direction our disturbances is corrected. And this is important to take on in the following. First, a couple of definitions so we all know what we're talking about. So base excess has the benefit of only describing the metabolic disturbances and not being affected by the acute variation in respiration, unlike bicarbonate, which will always be affected by the level of PCO2. The definition of base excess is the amount of acid or base that needs to be added to get to a pH of 7.4, giving a set of conditions. Important also to recognize is that this represents or describes the resulting value, meaning the summary of all disturbances. What does that mean? That simply means that if you have two different causes of metabolic acidosis, for instance, lactate and ketones, you have lactate of 2 and ketones of 4. Your resulting value, your base excess, would be -6. It's always the summary. And that also goes if you have a concomitant metabolic acidosis and a metabolic alkalosis. What you would read on your blood gas is the summary of all these disturbances. The normal range starts at 0 and goes from -3 to +3, which makes it even more simple than to interpret the bicarbonate itself. Base deficit is the same as base excess, but with the opposite sign, meaning a base excess of -10 would be a base deficit of 10. Millimolars is the same in this context as milliequivalent, so you don't have to worry about the units. How about the SID? Well, the strong ion difference is the difference between the strong cations and the strong anions in plasma. You will see here the most common cations being sodium, potassium, calcium, magnesium on the one hand, and chlorine and lactate, the most common anions on the other hand. Fortunately, we can simplify it down to sodium minus chlorine. And the normal range of that should be 38 or from 36 to 40. And that's actually quite important to recognize. Because if you have any discrepancies from this, for instance, you have too much chlorine, you will have a hyperchloremic acidosis. And that is, if chlorine is high, so sodium minus chlorine would be below 36. Or on the other side, if you have too little chlorine, you have a hypochloremic alkalosis. And that is if sodium minus chlorine is more than 40. So now looking into the blood gas itself, what do we expect from a metabolic acidosis? Well, we expect the pH to be low. Does it have to be low? Not at all, because we can compensate, and sometimes we can even compensate up to where we get to a normal pH by our ventilation. We will still expect the pH to be low. The PCO2 we will always also expect to be low, because that is our natural compensation from the body. Does it have to be low? It doesn't at all. Sometimes we're not able to compensate for some reason. And we also found, actually by coincidence, that having a severe metabolic acidosis without a compensation with a low PCO2 actually has a poor prognosis if you have a methanol poisoning. And that's probably because you're about to decompensate. The level of oxygen is not really affected by whether it's a metabolic acidosis or not, but bicarbonate and base excess is always low, and that's per definition. So let's have a look into a blood gas and look at what kind of information a blood gas can give us, because it's actually quite a lot. Let's zoom in for those of us who need glasses, and even if we don't drink methanol, some of us will have a reduced vision, so we'll try to make it bigger. This will now tell us a very simple acid-base status. Look at the parameters in red and pay a special attention to the base excess and the lactate. Knowing that not all blood gas machines give you a lactate, the majority will. And this relation between lactate and base excess is a very crucial information that we can use in the following. We can also read the strong ion difference from our blood gas by the electrolytes. Be aware of one thing, and some blood gas machines will be very inaccurate when it comes to chlorine. The chlorine sensor is very poor on some of these machines. Whether that goes for your machine or not, for your blood gas machine or not, it's very easy to figure out. If you have a patient coming in, especially if you have a patient with a metabolic acidosis, draw a blood gas and send a sample to the lab at the same time. Then you will see whether your chlorine is trustable or not. If you cannot trust your chlorine in the blood gas, then always use the one you get from the lab. That also goes for the anion gap, but which you can calculate based on the blood gas alone. This all being said, the osmolar gap cannot be calculated or not be found on a blood gas machine. That being said, it doesn't mean that you cannot necessarily find it on your machine, because some blood gas machine, a few blood gas machine would report an osmolality. A take-home message to you all now is never, ever use it, because osmolality needs to be done by a freezing point depression method, which is done in the lab. If you do it on a blood gas machine, it's done either by a vapor pressure method, which will not detect the volatile alcohols and thus give you a false negative result. Or, as for the majority of the machines, it doesn't measure it at all. It calculates a fictive osmolality or osmolality based on a fictive urea bond. So again, never ever use it if that's the only source of osmolality you have. So now let's look into the step 1 of our calculation. We have our patient with an acidosis. We can see the pH being 7.2. It's clearly a metabolic acidosis, as the base excess is -24 and the bicarb is 5. There is the respiratory compensation, as our PCO2 is about 14, 15 millimeters of mercury, and lactate is 19, whereas our base excess is -24. The anion gap is 38 by calculating the figures you'll see on the blood gas, and the SID is 38. That is exactly what we expect it to be. Sodium minus chlorine, 38. That means that there is no hyper or hypochloremia interfering in our blood gas. As an additional information, glucose is 14, and we are not going to focus on that today, but it's certainly a useful information to bring along. As a temporary conclusion, we have a severe metabolic acidosis with a respiratory compensation, that's for sure. It's mostly a lactic acidosis. It could actually be glycolate as well, and I'll come back to that in a second. And if looking at base excess versus lactate, you will find that lactate contributes most of the base excess, actually 19 out of the 24, which leaves only 5 millimolars left over after we've subtracted the lactate contribution. And similarly, with the anion gap, when we subtract that, there is only 19 millimolars left, and that brings us actually down to the reference range. So in theory, we have a lactic acidosis potentially combined with ketoacids. We don't know that yet, but that can be a working diagnosis. And a suggestion could be an alcoholic ketoacidosis. And again, we don't know that yet, but this could be our working theory. Next step up would be to rule out the toxic alcohols. But before that, I will just mention lactate versus glycolate, because most blood gas machines use glucose oxidase, and it's not able to separate lactate from glycolate. So it might be that if you have an ethylene glycol poison patient, it may show up as lactate, whether it's in reality glycolate. And you don't really know that when you look at your blood gas. So keep it in mind. What toxic alcohols do we have to are the most common ones? Well, first of all, it's methanol. Could it be methanol? It could. There could be methanol in our patient. But if so, the majority of the acids or the anions is still lactate. And there's only room for a few millimolars of formate. Looking at the base excess. Sorry, now it's living its own life a little bit here. I'm trying to get it back. Here we are. So Knowing the mechanism of methanol, it will inhibit the mitochondria. So for sure, we will have an increase in lactate at one point. But before you have sufficient inhibition of the mitochondria, you will have around 20 millimoles of formic acid or formate. That's when your lactate begins to increase. Whereas here, it's the opposite way around. There's plenty enough of lactate and not so much else. So for sure, if this is like methanol, it's regardless not the reason for our patient to have severe acidosis. How about ethylene glycol? Well, this is the clue. The lactate could be glycolate, and that's why we could not really exclude ethylene glycol from being the cause of this patient's trouble. Could it then be isopropanol? Not really. Why is that? Isopropanol is metabolized to acetone and no acids. So that's probably or definitely not the reason why we have the condition we have. So what we're left with now, we have interpreted our blood gas and we want to go forward. And even before having any other results from the lab, being it osmolality or other lab results, we can do the second step, and that's a supplementary test. If we have formate analysis available, we can run it now, and that would tell us very quickly whether we are dealing with a methanol poisoning or not. Usually formate analysis is not available, and that's why we have introduced the fluid trial. And let's have a look on what that is. And before we do that, we need to look what the most common differential diagnosis to toxic alcohols are. It's the diabetes ketoacidosis and the alcoholic ketoacidosis. As for the DKA, it's characteristically having a high glucose, either 20 millimoles per liter or more than 360 milligrams per deciliter. The acidosis itself comes from ketoacids, whereas the majority of the ketoacids is beta-hydroxybutyrate and not acetoacetate. Whereas the urine dipstick, on the other hand, identifies acetoacetate and not BHB. That means you can have a quite limited amount of ketones on your urine dipstick, whereas there could be quite a high amount of ketoacids in the blood. Be aware of that. There can also be a moderate increase in osmolar gap from acetone, but we're not going to focus on that right now. The alcoholic ketoacidosis is somewhat more complex. I've tried to sort of extract the most important parts. And knowing that alcohol or ethanol can give us several things, including typically a low extracellular volume. This would in turn give us both a production of ketones and an excess of pyruvate, giving an increased level of lactate. That, in addition to that, our patients with alcoholic ketoacidosis is typically not eating all that well. They're drinking, but they're not necessarily taking the necessary nutrition, which means that ketones are being produced as a source of energy for the patients. Lactate is also increased by other mechanisms, and here is a handful of different reasons. Whereas one of the important ones is lack of thiamine in this group of patients. If this simplified sort of chart still makes it difficult to remember, the good thing is that you don't really have to remember all the pathophysiology. What you have to remember is the fluid trial. Because if you give your patient IV fluids, preferably ringer acetate or ringer lactate, and not sodium chloride, because if you give your patient a lot of sodium chloride in a short time, you will give them even more metabolic acidosis in the form of hypochloremic acidosis. But give them fluids, then give them thiamine, and thereafter you give them glucose. If then you supplement that by insulin, because you don't want a higher glucose or a lower glucose. What you want is the same glucose level, but you want to provide energy intracellularly to help out with the ketone production. This is what we call the fluid trial. And if we add that to our patient after our potential formate analysis has been done, we'll give 1 to 2 liters of fluid, thiamine and glucose, and if your acidosis would either stabilize, improve, or even completely be corrected within 30 to 60 minutes, because that's all the time it takes for this fluid trial to be tested, this is no toxic alcohol. Whereas if this acidosis gets worse, it's very likely a toxic alcohol, and in this context, it's most likely ethylene glycol. So this is an extremely simple tool we can use in all settings as long as we have a blood gas and we have a metabolic acidosis. So bringing us from here into the third step, and I'm going to go through this a little bit quick just to make sure that we know how we can use the osmolality and the anion gap put together. First of all, the anion gap, the simple one, is the difference between the most common cations and the most common anions. We call it the anion gap, and there is, for all of you present, an anion gap right now. The physiological anion gap consists of what? It consists of the negatively charged proteins, and that is predominantly albumin. Is that worth noticing? Yes, it is, because if you have a hypoalbuminemia, if you have a very low albumin, there could be something else being hidden in the anion gap, which is not albumin as we would expect, while still the anion gap is normal. But by subtracting the most common anions from the most common cations, we can easily calculate the anion gap. The metabolic acidosis with the increased anion gap, if you look at the equilibrium up to your right, whatever weak acid, which we're talking about in the serum, would this be more or less completely dissolved to H+, which gives us the acidosis, and an anion, which gives us the anion gap. This could be lactate, it could be ketoacids from either hunger, diabetic or alcoholic ketoacidosis, it could be uremia, or it could be a set of poisonings. Most commonly, methanol or ethylene glycol, sometimes salicylates, sometimes organic acids or other, like for instance cyanide, that gives you tissue hypoxia, but these will all give you an increase of lactate. The common thing is that if you look to your right, chlorine would be unchanged. The anions would take the place of bicarbonate that will buffer the H+ that is being produced. Then we have the situation of what we call the normal gap and metabolic acidosis, also called the hyperchloremic acidosis. Why is that? Well, remember the SID up and to your right, sodium minus chlorine. If you somehow have too much chlorine, well, you have the similar amount being reduced of bicarbonate because of the electrochemical neutrality. Whereas bicarbonate is a great buffer, chlorine is not. So you will have the neutrality and anion gap would be unchanged, but you will have an acidosis still. And this acidosis typically occurs if you lose bicarbonate through your intestines, if you have a renal tubular acidosis, or if, like mentioned already, you give your patient a very quick sodium chloride infusion. That means chlorine will take the place of the bicarbonate. Then how about the osmolar gap? Osmolality is sometimes confused, but it's actually quite simple. Osmolality simply describes the number of particles in serum. And that means that small particles in a high number will give a lot of osmolality, whereas big molecules in a low number will not contribute to the osmolality. And since we somewhere or in some lab can measure the total osmolality by a freezing point depression method. And we can also calculate the typical osmoles being present in serum. Sodium, urea bun, and glucose. We can calculate the difference, and we're ending up with the osmolar gap. Osmolar gap in a normal physiological condition is contributed by a little bit calcium, and other than that, is small lipids. And is that important? Well, actually, it is a little bit important, because if you have a very sick patient, could be a trauma or a very, very severely ill patient, you'll see that this patient has cell death. And these small particles being released from the cells can increase the osmolar gap without you knowing why. So when you calculate this, you can use the one on top, which we use. It's a little bit more complex. It's just describing 0.93 because that's the content of water in our serum. If you use the other one, which is commonly used, it's actually osmolality minus osmolarity, but it doesn't really matter because the figures is more or less exactly the same. And the reference range we use is below 20, 19 or below. What increases the osmolar gap? All alcohols does because they are small molecules. Critically ill patients because of the cell death. Alcoholic ketoacidosis, diabetic ketoacidosis, and also the poisonings. And then it's only methanol and ethylene glycol that remains. And if we look at how this actually works, these alcohols on top, methanol, ethanol, and ethylene glycol, would all contribute to the osmolality, whereas the anions, formate, and glycolic acid or glycolate would contribute to the anions on the opposite side. And if you remember this figure, you would also understand how to interpret the gaps. Just immediately after you've been drinking, you have a high level of ethylene glycol, or as here, methanol, the red line. Corresponding to that would be the high osmolar gap. The metabolism hasn't started. This black line, the formate is 0 and anion gap is within the normal range. And as time goes, you get down to where the metabolism has started. You get more metabolite and less toxic alcohol. Osmolar gap is decreased, anion gap is increasing. And eventually, you'll find an increased anion gap and sometimes even normal osmolar gap in the late stages where the patients are most severely ill. I will not go into calculation, but I will remind you about one thing. Osmolar gap is useless unless you calculate the level of ethanol in the blood, because that is, after all, the most common alcohol we have. And you need to subtract the osmolality from ethanol, being 24 per 100 milligrams per deciliter. And with that, I'm going to sum up, so I'm staying more or less within my dedicated time. Start out with a very detailed patient history and clinical features. Run your blood gas, have a look at it, and look whether your metabolic acidosis have a lactate that corresponds to base excess. If it does, you have a lactic acidosis or a glycolate from ethylene glycol. If you do not, make sure that you look for the other anions present. You can do that by a formate assay or a fluid trial. Then you can wait for your osmolality if you're lucky enough to have that in your lab. If they do not correspond and lactate is higher than the base excess, then you know that you per definition have a simultaneous metabolic acidosis and a metabolic alkalosis driving the base excess in the opposite direction. The SID would tell you something about whether you have a hypochloremic alkalosis, whether sodium minus chloride is less than 36. If it is where it's supposed to be at 38, you have a metabolic acidosis, not because of chloride, but you will have an increased anion gap. And whereas sodium minus chloride above 40 indicates a hyperchloremic acidosis and acidosis with a normal anion gap. Thank you so much for your kind attention, and my apologies for the speed.
Thank you so much, Erik. That was really, really insightful, and I personally enjoy using the base deficit method to do any of my acid-base problems. So you're accounting for almost, any of your missing osmoles, things like that. This is quite important, and it takes multiple times and practices to really get to understand this. So you guys will have access to this lecture, of course, on YouTube, and I'll also send you some other resources you can read about this method, which is really a fantastic method. If anyone has maybe one or two questions, we can do that before we move on to the next presentation. Please, you can type your questions down there.
And I can send you also the slides so you can have a look at them at your own time. And you'll also find some information on these websites, which I posted here. So come on, if there's any, but I cannot really see the, so if I'm just ending my presentation, my sharing, I might see.
Okay, great.
See if there's,
I will say that Dr. Knut Erik has been one of our experts in the Poison Information Center, and he is, he's always providing us with help with any questions that you have when it comes to, any of these things, including acid bases. So, especially if it's relating to toxicology, you can always reach out to the Poison Center, and he's one of our experts that helps us guide these things. But we can move on to the next one, and if there are other questions that they send you, we'll send them to you, Dr. Hovda, so that you can help us answer those in the future. All right, so now we're going to move on to our second presentation this month, which will focus on one of the major public health problems in Nepal, which is organophosphate poisoning. So I'm very proud and happy to introduce my sister, friend, and colleague who we have worked together for a number of years, Dr. Olita Shilpakar. She's an assistant professor of emergency medicine at the Department of Emergency Medicine at Tribhuvan University in Maharajganj. She's one of the first female emergency medicine physicians in the country, and has traveled to various parts of the world representing Nepal as well. She works with the government structure. She works with the Ministry of Health. She has been one of the leaders of the first standard treatment protocol for emergency medicine in the country. She, of course, cares for numerous organophosphorus cases, possibly in one day in her daily work. So we are really happy to have her come and talk to us about the management of organophosphorus poisoning acutely when they arrive in your emergency department or your health post. So I'm happy to introduce Dr. Olita Shilpakar, and Didi, the floor is yours.
Thanks so much, Ramu. Can you all see my slide?
Yes.
Okay, so it is moving, right?
Yes.
Is it?
Yes.
Okay.
Perfect.
Okay, thank you so much for that long introduction, Ramu. So namaste everyone, I'm Dr. Olita Shilpakar. I am an emergency physician. I work as an assistant professor in the Department of Emergency Medicine in Maharashtra's Medical Campus, Tribhuvan University Teaching Hospital. And I'm very glad to be here today. I would like to take this opportunity to thank the Poison Information Center, the Department of Clinical Pharmacology, Brown Emergency Medicine, and also Ask Foundation for giving me this chance to be with you all today. My topic today, as already mentioned by Ramu, is organophosphorus poisoning and its management in the ED, how we do it. So this is quite an interesting topic for me at least, and hopefully you all will also feel the same. So shall we begin then? Okay. So to start with, things are not moving, I guess.
So you're not moving right now.
Yeah, it was moving earlier, so I'll stop and I'll share one more time, okay? Hope that will be okay. So is it moving now? Not yet?
Not yet.
What's happening?
Navay, we can have Rajesh share it here, and he can move for you if you
We'll
want.
do it one.
Let's see. Yeah, let's try one more time.
Yeah, I'll share one more time. Not yet? Uh-oh.
No, we're just in the first slide. We're seeing the management of organophosphorus. Oh, okay, you want to share it then? Didi, is it okay if Rajesh shares it?
Okay. Okay, so the contents for today's presentation, I'll be talking about the introduction, then the history, a bit on epidemiology and the scenario in Nepal, the mechanism of action of organophosphorus. We'll also be dealing a bit about the clinical features, then the diagnosis, management, and also mentioning a few newer therapies. And we'll be ending with the challenges that we are facing and some recommendations. Next slide. So I would like to start with a few scenarios. These are not made up scenarios. These are real scenarios that I have been facing almost every day in the emergency department. So I will not be discussing all the cases, but just the scenarios that I have, tackled. So a 25-year-old lady found unconscious in a room with a bottle of insecticide near her, and she was rushed to the ED. A 40-year-old farmer, drowsy, having difficulty breathing after spraying his field with pesticides. We've also had an 80-year-old elderly male abandoned by his children, and he was brought to the ED by neighbors after consuming a bottle of 50 ml of bottle of insecticide brought from a nearby shop. And also a 45-year-old housewife on a medication for depressive disorder brought to the emergency with alleged history of consumption of and insecticides. So these are the real scenarios that we have been facing. Maybe many of you who have been working in the emergency have faced these kind of scenarios, cases in your day-to-day practice. So introducing organophosphorus, these are compounds that are used for agriculture. Our country being an agricultural country, we are using these kind of organophosphorus compounds a lot. These are chemical agents. These can also be used as nerve agents and therapeutic agents. If you can see this picture, this is the general structure that describes an organophosphorus. If I have to go in a bit detail, it is made up of ester, amide, or thiol derivatives of phosphoric acid with the R1, R2 groups, and these are composed of either the methyl or the ethyl moieties. Next slide. So just a bit about the history of organophosphates. It dates back to early 1800s, the first synthesis of organophosphates. Then 80 years later, it was used by the German military for warfare. And during the World War II also, it was introduced worldwide as a pesticide. And even till date, nerve agents like sarin, they were delivered by rockets during the chemical warfare during the attack in Syria in 2013. Next slide. So just in brief about the epidemiology, we have many articles, which talks about the major public health problem that this compound has brought. It is a major clinical and public health problem across mostly the developing countries, and this is responsible for at least 5 million deaths over the last 3 decades. It has been estimated that 25 million farmers from these countries, mostly from the developing countries, suffer from acute pesticide poisoning annually. These are staggering data. And the self-poisoning accounts for 1/8 of the world's suicides and about 60% of the deaths, mostly in rural Asia. So what is the scenario actually in Nepal now? We have many articles in reputed journals from Nepal. The data say that organophosphorus compounds are the most common poisoning agents that comprise of 50% of total cases. And they also hold a major share in the inpatient mortalities because of this compound in Nepalese hospitals. So if you can see the picture, if you can go back, I would just like to show a picture of a person buying maybe an organophosphorus compound for some reason or the other, but I would like to mention that this is available over the counter. So maybe these data are probably due to the reason that it's available everywhere very easily. Next slide. Next. So just a few articles. This was published by a group of doctors, emergency doctors from Bake. It says about the organophosphorus poisoning among the acute poisoning cases presenting to the emergency department. And out of the 427 patients that they received, 203 had organophosphorus poisoning. And the age group was 16 to 30 years among these. Next. So we also have a few studies from Tribhuvan University Teaching Hospital, a few retrospective studies, where the pesticides, they are the major cause of poisoning and they account for majority of cases of toxicology. And the study also concluded that the younger age group were mostly affected, and they have also recommended that regulatory measures are required for control of the easy accessibility of these kind of substances. Next. So this article is from our very own Dr. Rakesh Kimire and team. And this is a very important article. It talks about the intentional pesticide poisoning and pesticide suicides in Nepal. So the data is again very staggering. The intent in this article, it says that 95.8% of these cases were suicidal, and organophosphorus poisoning was seen in 57.7% of these cases. Most of them consumed dichlorvos. Next. So if I have to talk about Tribhuvan University Teaching Hospital emergency where I work, this is just the raw data. And the poisoning cases in the TUTH ED in 2023, we had a total number of poisoning cases, 264 poisoning cases, out of which organophosphorus poisoning cases were 78. So it comes to around 30% of cases. Next. So these are some of the common organophosphorus pesticides that are available in Nepal. These are the brands available, and I think most of you might have heard about metacid poisoning. This term is so common in Nepal. So if you look at this picture, most of the shops, pesticide shops, have all the availables, like brands at a very low cost, or they're very easily available. So these are the common organophosphates. So talking about the mechanism of action, these compounds, they are powerful inhibitors of acetylcholinesterase, and they are responsible for hydrolyzing the acetylcholine to choline and acetic acid, if you can look at the picture over here. And these organophosphates in red triangles, they inhibit the cholinesterase enzymes irreversibly. Acetylcholinesterase in the synapse and on the red cell membranes, and butyryl cholinesterase in the plasma. Next. Next slide. The previous slide. So this slide, it also talks about the accumulation of acetylcholine. If you can see the green structures here, these structures, there's accumulation with hyperstimulation of cholinergic receptors at the neuromuscular junctions and in the autonomic and the central nervous system. Next slide. So I would also like to talk about aging. This is a very important term, I guess. It is the irreversible conformational change that occurs when the organophosphate is bound to a cholinesterase enzyme for a prolonged time. So this is important because it is rapid, about 3 hours with dimethyl compounds, and it is quite longer. It takes quite longer, about 30 hours or so in diethyl compounds. And this is very rapid in case of nerve agents, like within minutes. So this irreversibly resistant to the reactivation by an antidotal oxime. Next slide. So let's talk about the clinical features now. The clinical features depend upon the agent that is involved, how much quantity is absorbed from the body, the route of exposure, and also the amount, and also the character of the additive. So we'll be discussing about acute poisoning, the clinical features when there is acute poisoning. We'll also be discussing about intermediate syndrome in brief, chronic toxicity, and organophosphate-induced delayed neuropathy. Next. So if I have to discuss about the acute cholinergic syndrome, you can look at the picture. They are toxidromes. And in case of organophosphates, the toxidrome is known as cholinergic toxidrome. And the manifestation of cholinergic excess, the patient is symptomatic within the first 8 hours, and nearly all of the patients, they are symptomatic within the first 24 hours. And these effects, they involve the autonomic nervous system, the central nervous system, and also affects the neuromuscular junction. So if you look at the picture here, the person is having pinpoint pupils, meiosis, sweating, the person is crying, there's lacrimation, there's running nose, is vomiting, there's diarrhea, bradycardia, and urination. So next slide. We are all familiar with the mnemonics. We have been studying this in our medical school as well. So the muscarinic effects of cholinesterase inhibition, we can remember this as sludge. So it is the previous slide: salivation, lacrimation, urination, defecation, and GI cramps, and emesis. More mnemonics, dumbbells, which stands for diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, and salivation. Something very important here are the 3 killer bees, I would like to call them. That's bradycardia, bronchuria, and bronchospasm. And bronchuria specifically is the usual mechanism for early morbidity or mortality. So we have the nicotinic, next slides, the nicotinic effects also of cholinesterase inhibition, which may present with muscle fasciculations, weakness, mydriasis, tachycardia, hypertension, and also paralysis, which is also graded as type 1 paralysis. Next slide. So there are CNS effects of cholinesterase inhibition as well that can come with anxiety, restlessness, emotional lability, or tremors, headache, dizziness, confusion, delirium, hallucinations, seizures, and also coma. I would also like to discuss a bit on intermediate syndrome. This is a syndrome that occurs about 2 to 5 days after the exposure in about 10 to 40% of the cases. This is also known as graded as type 2 paralysis. What happens in this syndrome is that there is neck flexion weakness. So if we tell the patient to raise the head from the pillow, they cannot do it. There are decreased deep pterygium reflexes, cranial nerve abnormalities, proximal muscle weakness, and also respiratory insufficiency. The exact mechanism is not known, but we have quite interesting case reports related to intermediate syndrome presenting as extrapyramidal oromandibular dystonia due to organophosphate inhalation. This was a quite rare case report that was published last year. So talking about the chronic toxicity, this is seen mostly in the farmers who work daily and get exposed to this toxic agent. And it is manifested as a symmetrical sensorimotor axonopathy. There are leg cramps, weaknesses, paralysis, and some may also mimic GBS, that is Guillain-Barré syndrome. Talking in brief about organophosphate-induced delayed polyneuropathy, this is also known as type 3 paralysis. There is sensorimotor distal axonopathy. There are quite interesting case reports about organophosphate-induced delayed polyneuropathy also. This occurs after ingestion of large doses of organophosphate. And this mostly follows a latent period of about 2 to 4 weeks during which the person is normal, and then the person is followed by cardinal symptoms like distal weaknesses of hands and feet. There might be cognitive dysfunction, impaired memory, mood changes, autonomic dysfunction, peripheral neuropathy, and extrapyramidal signs. So this is also quite an interesting and important clinical feature. So if we have to come to the diagnosis of this condition, this is mostly done as per the clinical suspicion. There are clinical signs, and the thing that we need to remember is the presence of a suggestive toxidrome. In this case, it is known as the cholinergic toxidrome, which I've already mentioned earlier. There is a typical characteristic petroleum or garlic odor, and there are confirmatory tests as well, known as confirmatory assays, acetylcholinesterase assays, which measure the butyryl cholinesterase or acetylcholinesterase in the blood and the plasma. But one thing that's very, very important that we need not forget is that we should not delay the administration of potentially life-saving therapy just waiting for the reports. Next slide. So a bit about the history. We should make a good effort, a noble effort to identify the agents. We should also try to retrieve the bottles if they are available, or even photographs if possible. And the intent mostly is suicidal, could be accidental or homicidal as well. The route of entry, we all know, ingestion, inhalation, and absorption. And the 5 important points while taking the history should be agent, dose, duration, clinical features, and comorbidities. So talking about the cholinesterase assays, the confirmatory tests that I just mentioned, there are 2 kinds of cholinesterase, RBC or the true cholinesterase and plasma or the pseudocholinesterase. RBC cholinesterase, these are more accurate, but this is not available in the country. Quite difficult to get these tests done. But then this measures the degree of toxicity and also the severity of the poison. So this is a good marker of inhibition in the synapses. And they are used to determine the effectiveness of the enzyme therapy and helps in the regeneration of enzyme. But plasma or pseudocholinesterase, they are easily available tests available at our place also, but then they do not correlate well with the severity of the poisoning. So basically, they should not be used to guide the therapy. Next. There are other tests as well that hold prognostic value, like electroneuromyogram, blood glucose, where we can find hyperglycemia, blood counts. We can encounter neutrophilic leukocytosis, blood pH, where we can see metabolic acidosis, ECG. We can encounter ECGs with QTc prolongation and hyperamylasemia, acute pancreatitis. So coming on to the most important part, that is the management. The management of organophosphorus poisoning, I think it starts from the pre-hospital care itself. So spot decontamination, at least throwing away the soaked clothes, the contaminated clothes is important. Early toxidrome recognition is important. If we have antidotes for a certain compound, to use early antidotes to save preventable deaths, and extensive decontamination and the hospital care to complete the care of the patient is important. So initial stabilization is the key. Our very own ABCDE needs to be addressed. So in airway, the positioning is important. In breathing, chest sounds, we listen to the chest sounds and start high flow oxygen. Also intubate if the airway is compromised, and avoid succinized choline because it is metabolized by the acetylcholinesterase. Coming on to the circulation, blood pressure, heart rate, very basic things, but very important things. 2 IV cannulas, intravenous access should be there. And the endpoints should be systolic blood pressure more than 80 and urine output more than 0.5 ml per kg per hour. In disability, we need to address the level of consciousness. We need to look for whether the patient is conscious or not. We need to do a random blood glucose and also check the pupil size. And exposure and examine, this is something, again, very important. Removing the sore clothes, looking for whether the patient is sweating or not, that is also important. So this one's for us, I guess, along with the patient's condition. Dermal decontamination, preventing ourselves by protecting ourselves so that we are not poisoned. The healthcare workers should also be carefully protected. So we need to have our gears, our gloves, our personal protective equipments and stuff. The complete removal of patient's soaked clothes and vigorous irrigation of the affected area is important. Washing the patient thoroughly with soap and water is important. Coming on to the gastric decontamination, gastric lavage. This is done only if the patient arrives within 1 hour. And this is also done if only the stabilization is achieved with oxygen, atropine, and oximes. And we should consider this if the patient is intubated or conscious or the patient is willing to cooperate. If we have to mention activated charcoal, the standard dose is 1 gram per kg. Maximum dose of 50 grams can be used, but there have been randomized trials that suggest that activated charcoal given after the first hour, this does not have any benefit to the patients. There have been quite important studies about the hazards of gastric lavage for intentional self-poisoning in a research-poor location. So our very own atropine, very important drug in organophosphorus compounds, in organophosphorus. The previous slide, please. Previous slide, please. The previous slide, please.
Which one? This one or
the previous slide? The previous slide. Yes.
Okay.
No, not the atropine. Atropine slide.
Okay.
Yes. After the slide. Okay. So let's talk about atropine because this slide is very important. That's why I would like to take 1 minute to discuss about atropine. This is a muscarinic receptor antagonist, and we all know that it has been there since forever. Since 1950s, this is being used as the antidotal treatment for organophosphorus poisoning. And this is effective when these muscarinic receptors are overstimulated by acetylcholine. This is easily available, this is widely available, this is affordable as well. But there have been studies where atropine has been compared with glycopyrrolate. There have been studies where there is grading and the severity and comparing the treatment between atropine and glycopyrrolate. But then the glycopyrrolate is seen to have less CNS penetration. They produce less central anticholinergic toxicity in overdose. It is a poor antagonist of the central effects of lipid-soluble OPs. So this study found that there was no difference in mortality or intubation rates among the two. Next slide. Next slide. So this one is, again, a very important slide. The previous one, atropine doses. The previous slide. The previous slide, Rajesh. Okay, so we need to spend a bit of time on this slide, I guess. Atropine doses, what we do in the emergency is we first load a bolus dose of 0.6 to 3 mg IV rapidly. And then we administer doubling doses every 5 minutes until the patient is atropinized. So 5 minutes after giving atropine, we need to check for the pulse, the blood pressure, the pupil size. We need to check for sweat and also the chest sounds. If there is no improvement, we double the original dose of atropine. But once these parameters improve, we cease the doubling of the doses. And what we do after this is we use similar or smaller doses. So we give atropine boluses until we achieve the heart rate more than 80 beats per minute, the systolic blood pressure more than 80 millimeters of mercury, and the chest is clear. Next slide. So there was an open-labeled randomized clinical trial of atropine bolus injection versus incremental boluses plus infusion for organophosphorus, and this was done in Bangladesh. The conclusion that was drawn from this particular open-label randomized controlled trial was that rapid incremental dose atropinization followed by atropine infusion, it reduces mortality and morbidity from the organophosphorus poisoning, and this shortens the length of hospital stay and recovery. Next slide. So what is atropinization? What are the target endpoints of atropinization? We need to see whether the lungs are clear or not. This is done by auscultating the patient. So drying of pulmonary secretions with clear lungs on auscultation, the heart rate, already mentioned, more than 80 beats per minute, systolic blood pressure, more than 80 millimeters of mercury, pupils should no longer be pinpoint, and the axilla should be dry, the bowel sounds should be just present. But one thing that we need to focus is that tachycardia and mydriasis, these are not appropriate markers for therapeutic improvement, because this may indicate that maybe there's hypoxia or hypovolemia or sympathetic stimulation. So after atropinization is achieved, after these target endpoints have been achieved, we need to set a maintenance dose. This is done by an infusion of around 20% of the total dose, which is required to atropinize the patient every hour. So if we have recurrent cholinergic toxicity, what we do is we restart the bolus dose. We need to atropinize the patient again. So we increase the infusion rate by 20% per hour. Next slide. But then we might also encounter atropine toxicity that can have features of tachycardia, absent bowel sounds, hyperthermia, delirium, and urinary retention. So what do we do when we have atropine toxicity or when we encounter atropine toxicity? So we stop the infusion for 30 minutes and we start again at 20% lower dose in such cases. Next. So talking about oximes, pyralidoxime is used very commonly in our part of the world. These oximes, they reactivate the acetylcholinesterase that is inhibited by the organophosphorus poisoning. As you can see, the mechanism action of organophosphate and pyralidoxime in this diagram as well. There's reactivation. Reactivation, this is limited by aging of the acetylcholinesterase. Aging, I've already mentioned in my previous slides. And aging of acetylcholinesterase takes longer with diethyl-OP than with dimethyl-OP compounds. So aging is very important for oximes to act. Next. We are still using the WHO recommendation when it comes to oxime dosing. The bolus dose is 30 mg per kg in adults and 25 to 50 mg per kg for children, with the maintenance dose that is a continuous infusion of at least 8 mg per hour in adults. But there needs to be, we need to be very, very careful while administering these drugs. It needs to be given very slowly over 30 minutes because it has been seen that rapid administration has been associated with cardiac arrest in some cases. Next. So what are the therapeutic endpoints of oximes? So when there is resolution of muscle fasciculation and weaknesses, when there is increment in the level of the acetylcholinesterase levels, we can stop oximes, but the infusion is continued until the patient remains symptom-free for at least 12 hours without additional atropine. And if the patient is intubated, we need to still continue the oximes. But then something very important, pyralidoxime should not be administered without concurrent atropine in order to prevent the worsening of symptoms, because there might be transient oxime-induced acetylcholinesterase inhibition. Next. Next. But then there are controversies when it comes to oximes, because there is mixed evidence regarding the clinical effectiveness of these drugs. There has been a Cochrane collaboration review, and this was reported recently, and this says that there was insufficient evidence to determine whether these are they are effective or not. And pralidoxime was also not selected for the WHO's essential drug list in 2008. Next. So benzodiazepines, these are again important drugs. This is the first line drugs. If there is organophosphorus agent-induced seizure, then this is the drug that we use. We do not use phenytoin or any other drugs. Benzodiazepines are the drugs that we use. And what these drugs do is that they reduce the neural damage and prevent respiratory failure. Also, these are done in animal studies. Diazepam, lorazepam, or midazolam are the preferred benzodiazepines at the following doses. At the dose of 10 mg given IV slow push, this may reduce agitation, and they can be repeated also. Next. Magnesium sulfate is another drug that is being studied, and this is an inhibitor of acetylcholine release in the central nervous system, also at the peripheral, sympathetic, and parasympathetic synapses. It has been said that this improves the outcome, but there have been only 3 small studies where the IV administration of magnesium sulfate produced improvement in the neuromuscular junction. So more studies need to be done. Next. So there are newer therapies as well. I will not be going into the details of these drugs, but then there is a very good article by Dr. Michael Edelston in the British Journal of Clinical Pharmacology, where he talks about the pharmacological treatment of organophosphorus insecticide poisoning, the old and the possible new. So if anybody is interested, you can go back and then go through this article where he has described newer therapies. So in newer therapies, there's clonidine, there's alkalization with sodium bicarbonate, fresh frozen plasma, OP hydrolases, lipid emulsions, early enteral feeding, and antioxidants. Next. So almost towards the end of my presentation, I would like to talk about the challenges that we encounter in terms of resources. Our country being an agricultural country, there's routine use of these organophosphorus compounds, the toxic compounds. Having said that, there is limited resource and also infrastructure for healthcare delivery. The intensive care beds and ventilators are also limited, so we have to manage these kind of patients, even the critically ill patients in the open wards or in the ED, like that picture that's being shown. One problem would be the easy availability of toxic compounds and the limited availability or even lack of antidotes. Next. Next slide. Next. So there are challenges for physicians like us working in the ED. There are challenges in terms of mimickers. I have encountered quite a few myself, and I've reported them as well. There was a case of organophosphorus poisoning, which we thought that this was organophosphorus, but after having retrieved the bottle, it was a formamidine group of compound known as amitraz, and this presented exactly like an organophosphorus. Next. There was one more case of cypermethrin poisoning, which manifested with prolonged bradycardia. So this also was kind of a mimicker, and we were kind of confused whether this was actually an organophosphorus poisoning or something else. Next. So this was a rare case of a herbicide poisoning. This was a rare herbicide known as prettilachlor, and this was kind of masquerading as an organophosphate toxicity. So these are quite a few challenges that we face while working. So last but not the least, I would like to mention some recommendations. We need to encourage multicentric research on the evaluation of toxicological agents. We also need to have toxicological laboratories so that these pesticide compounds can be identified properly. The Narcotic Drug Control Act is there, but it should be strengthened for pesticide regulation and also for the public health. Awareness and also education to the public on at least the primary prevention of poisoning should be done. Mental health awareness for suicide prevention is another important topic to be discussed about. And knowledge among the physicians regarding mimickers of organophosphates, I think that is also something very important that should be discussed. And precautionary measures like redesigning the containers with at least the warning labels should also be done. And poison information centers for better poison treatment, which would lead to effective decrease in the pesticide poisoning and lesser death cases in Nepal. So the Poison Information Center, this is doing quite a wonderful job, I should say. Next. So yeah, with this, I would like to conclude my presentation. These are my references. If you want to go through the references, next slide. Thank you so much.
Thank you very much. Dr. Ram is there?
Yeah, I joined from a different computer here.
No problem. Please carry on. Yeah.
That's okay. No, thank you, Dr. Olita. This was a really great presentation and a great overview of a major health issue in our country. I know there are a lot of questions that you answered within your presentation. Thank you, participants, for sending the questions beforehand. If there are other questions that you have as far as from this presentation or Dr. Knut Erik's presentation, please write down. There was a question here, Dr. Olita, about from Pukar, who says, can you talk about challenges in uneducated population and the use of oximes without adequate timeline during history? Do you have any thoughts on that?
So about the uneducated population. Okay, so that's why I think one of my recommendations were to make the public aware about at least the symptoms and at least the primary prevention or primary management. Maybe the pre-hospital care part has to be taken care of. Even if somebody comes with an early decontamination, then I think we will be decreasing the severity of this disease. The other question was on...
Right, thank you. The other question was regarding starting of oximes if a patient doesn't arrive within 24 hours.
Yes, oximes, if they work only if, you know, if there's no aging. So I've mentioned about aging. So if the irreversible change has taken place, then there is no use of giving oximes. So I think it's up to the clinician. It's the clinician's discretion whether to use it or not if the patient comes within 24 hours, after 24 hours, as per the question, right? Yeah.
Right. And then one question here. I think we only have time to take one more, and we're going to compile the list of questions and have people kind of, you know, we'll respond to them. One question was about the use of magnesium sulfate and its dose and timing. Is there any used in organophosphate poisoning?
Yeah, it's, I think Dr. Rakesh might want to answer that question because his thesis was on, he did an acid as, so over to you, if you want to.
Yeah, thank you, Olivia. Thank you for the, Thank you, Didi. So regarding the use of magnesium sulfate, so there has been a few studies done on the effectiveness of this magnesium sulfate. And there is no any promising result till now. I also had an opportunity to do my thesis on the effectiveness of magnesium sulfate. And in my result, I found that there has been decrease in the number of hospital stay and the use of atropine to the people who has received the magnesium sulfate as compared to those who have just received the standard treatment. So for now, the use is like there are a few study has shown its efficacy, but the data is not that sufficient to have its use clinically in the patient. And regarding the mechanism of action, it blocks the calcium channel and it decreases the release of acetylcholine from the presynaptic junction so that it won't go into the synaptic cleft and then act on the cholinergic receptors. So this is how it works. I think I have cleared the question.
Yeah, thank you.
Yeah, thank you. Thank you, Dr. Rakesh. This is, of course, we don't see this in the United States a lot, so I have no clinical experience treating this. So really good to hear from both of you. And thank you, Dr. Olita, and thank you, Dr. Knut Erik. Before we end, I would like to invite our collaborator and the lead of the Nepal PIC on the clinical pharmacology department side, Dr. Rakesh Gimire, who you just heard from, to give a vote of thanks to our speakers as well as our audience and to end the session. Please, Dr. Rakesh.
Thank you, Dr. Ramu. Thank you everyone for your last presentation in this webinar. Our first presentation was on the metabolic acidosis, a simplified approach for clinician by Professor Knut Erik Hovda. Dear Professor Knut Erik Hovda, on behalf of everyone here, I would like to express our heartfelt gratitude for your insightful presentation on acid-base disturbances. It has been a privilege to know you for 6 years now, and coincidentally, my first encounter with your expertise was during the same presentation at APMT, Asia Pacific Association of Medical Toxicology, back in 2018 in Bali. And then I again got opportunity to learn from you on 2019 and 2023 last year in India, and this marks the 4th time I have had an opportunity to learn from you on this topic. And each time you managed to simplify the complexities of acid-base management, making it even more comprehensible. Your stepwise approach was particularly enlightening during this your presentation in this webinar. Your detailed elaboration on diabetic ketoacidosis and alcoholic ketoacidosis provided valuable insights, especially considering our limitation in Nepal, where we solely depend on the calculated osmolality due to the lack of laboratories. We don't have the facility to measure the osmolality in the serum. And then since, as you may know, I have talked to you during our meet in the previous year, methanol poisoning outbreak happens time and again every year in Nepal, especially during the Holi festival in Tarai part of the country. So I'm sure the participants here are benefited by your enriched presentation. Thank you, Erik, for your continued dedication to educating and inspiring us. Your expertise is truly invaluable.
Thank you so much for having me.
So, yeah, thank you. Thank you for your time. And our second presentation was on the management of organophosphorus poisoning by Dr. Olita Shilpakar. I would like to extend my sincere gratitude for your enlightening presentation on the crucial topic of organophosphorus poisoning management. It was an honor to hear from someone with whom I have had privilege of working during my residency, particularly on my thesis concerning the effectiveness of magnesium sulfate in the treatment of organophosphorus poisoning. And I have shared my experience with you just before. And your comprehensive coverage on this topic, along with your insight on handling the complications such as inhibited syndrome and OPDIN, which we call organophosphorus-induced delayed neuropathy, and appropriate use of atropine, which is very crucial. And the judicial use of atropine can save many lives, and it prevents from the complication as well. And these are very invaluable information that you have given during this your presentation. Your expertise continues to contribute significantly to our understanding and approach to these complex cases. Thank you again for sharing your knowledge and your continued dedication to the field. And I'm glad to see your publication that you have been doing by when you see the cases. And I also got an opportunity to talk to you regarding the case report that you are publishing. Thank you so much for doing so much in the field of toxicology in Nepal. And lastly, I would like to extend my heartfelt thanks to everyone for this large participation in this webinar. Your active involvement and engagement have made this session truly valuable. Thank you all for contributing to the success of this event. So please remember our Poison Information Center, which is available 24/7, and the number is 01-450-2011 01 450 2011. For any poisoning cases, we are here to help you for the management of any kind of poisoning. Having said this, thank you again, everyone, for your large presentation. Go, Ramu. I think this is all for today.
Yeah,
Go,
thank
Ramu,
you.
you there?
It just
Oh,
left.
okay, Rajesh is there.
Yeah.
Yeah.
So
Okay, thank you, everyone.
Thank you, everyone. Bye bye.
Thank you so much.
Okay.
Thank you, Olita. Thank you. Yeah.